We're going to talk about something for which there really is a huge need, but very little evidence. And there are emerging models of care, and there are things that we know from the literature about what doesn't work and what might work. So I'll talk a little bit about that. I'm going to be a little bit provocative. I think we need to sort of think outside the box. And as Bill alluded to, I'm here visiting my parents. This is a deeply personal issue. My parents are very frail. And my father, I think, has had 4 falls in the last 3 months, but he's still classified as low risk. And so he can't access the system as well as he ought to. And our system really waits for things to happen to seniors, and sometimes it's too late. So the question is, how can we rejig things so that my parents stop falling and stay independent? So no disclosures here except that I am a geriatrician. I'll be talking about specialty medicine. I once thought about family medicine, and I do work with family doctors, so I'm coming from both points of view, I think. I get asked this question all the time, what's a geriatrician? So I think we want to talk a little bit about what this specialty is, and then what exactly is this thing that's problematic with aging? Because the fact that we have 100-year-old marathon runners should be something that's celebrated. But there are issues with aging patients. What's the role of the specialist? What can we do well, and where does our role fall short? How about primary care? How can they do more geriatric medicine, and how do we put it all together? So, geriatric medicine is interesting because it's one of the youngest specialties. And in fact, in 1973, there was a debate that lasted about 4 years about whether we actually needed geriatrics as a specialty. And there was a lot of protests from internal medicine, from family medicine, and finally in 1977 it was recognized as a specialty. And the first trainees began in the 80s, so it's a relative newcomer. We now have care of the elderly programs for family doctors. That's fairly recent too. And I think last year or the year before, geriatric psychiatry was officially recognized as a specialty. And yet this aging baby boomer tsunami has been predicted for years. So this is a very new field, relatively speaking. Speaking about what I do, I did 3 years of internal medicine, 2 years of geriatric medicine, and then 6 years of fellowship. So I've trained for about 11 years, and that's sort of what I do. I've trained to be a consultant, which is to give advice for really complicated patients. And we train in a lot of things. We do rehab, we do consultation, we do psychiatry, and all sorts of other things. So we're fairly generalists as far as specialists go, and I'll get back to that. That's an important point. When I look at the Royal College website, I see something very nebulous and non-committal. So geriatric medicine is the prevention, diagnosis, treatment, remedial and social aspects of illness in older people, mainly those 75 years or more. That doesn't really explain, because that could be any physician. It could be an orthopedic surgeon, but we're not necessarily calling them geriatricians. So what is it that we do? And then the next answer we often give is we look after frail people. And people say, well, what's that? So what's a frail person? And I've spoken to Frank about this. I think we have a marketing, branding issue in geriatric medicine. People don't know what we do. And if they don't know what we do, they're not going to come to us necessarily for help. So here's this tsunami business. And is it really a problem that we have lots of seniors? We've never had this many healthy seniors. So I think the first message here is the fact that we have an aging population is a success of our society, and I think that should be celebrated. But some people don't do so well. My parents, for example, are not doing as well. And those who are not doing so well progressively get at risk, greater risk of having poor outcomes, and those are the folks we call frail. So what do we mean by that? Here's sort of the scientific explanation about what it means. It's a state of reduced fitness and reserve, which means you're vulnerable to stressors leading to poor outcomes. What does that mean? It basically means for some seniors, as they get older, many things start to accumulate. They get heart disease, they get weakness, their muscles atrophy, they get dementia, they get all sorts of things. And the more things they have wrong with them, the less it takes to tip over the apple cart, which is why if you're an older person who takes gravel for sleep, you may look like you have dementia. So this is the idea, the essence of frailty. But how do we define it? Well, we can define it in terms of its consequences. So frail people are more likely to become disabled. They're more likely to have stressed caregivers and poor health. They're more likely to fall, end up in hospital and nursing homes. They're more likely to die. But the problem with that definition, it's a sort of an after-the-fact definition. Oh, look, this guy fell, must be frail. That's not very useful in terms of trying to prevent things from happening. There's many other ways, and I like this one because it's relatively simple. And it's developed from Canadian data, and the Canadian Study on Health and Aging looked at several thousand patients and assessed them over time, and essentially developed this scale, which is a categorization of frailty. And it's kind of nice because I can use it to teach medical students, and obviously we have these very fit people, this 100-year-old marathon runner who's up here. I'm probably a 2. I don't have too much active disease except my cold, but I'm not the fittest. You have people with chronic comorbid disease. They may have coronary disease or COPD, but they're otherwise well. This is an interesting category, the vulnerable. They look like they're slowing down, but they're still independent and they're not disabled, and we'll get back to that. And then progressively worse degrees of frailty. This is a key indicator. And this is really important in terms of trying to think about how we could develop a system that picks up these folks here, or maybe even up here. That senior like my father, actually my father's down here, but he's slowing down, and yet he's not frail enough to get access to more care. What do we do with guys like that to stop them from getting worse? This is this interesting data that was developed from this Canadian Study on Health and Aging. These are the risks on that frailty scale, and here's that level 4, the ones who are slowing down in terms of placement risk in a nursing home. So slowing down is a bad thing. It's that early sign of frailty that things are starting to fall apart. And this is an important group to target. So how do we do that? Well, let's try to explore this frailty concept a little bit more. Is it that you have multiple medical illnesses? Is it that you have different degrees of disability? Is it these things we call geriatric syndromes? Is it all of the above? Let's go through some of the data about this. So, yes, a lot of older people accumulate medical illnesses as they get older. Diabetes, heart disease, heart failure, and obviously the older you are, the more likely you are to have multiple medical illnesses. And in a way, the more things you have wrong with you medically, the more you are likely to cost the system money. So this is data from a year ago from CIHI that looked at healthcare utilization for seniors in different age groups, so 65 to 74, 75 to 84, and 85 and over. And they looked at it by age, but also by the number of medical illnesses that you have. And what you see, if you look down by the age group, the costs really don't change. So it's not really that people are getting older that's driving cost. What it is, it's the number of medical illnesses that drives cost, at least from that point of view. So if you have no chronic illnesses, you're not going to cost as much to the system. If you have more than 3, you are. But is that enough? Again, if you look at the frailty scale, there's a lot of people who are not frail who have multiple comorbidities. So it's possible to have medical illnesses and not be frail. So having multiple medical illnesses can contribute to frailty, but that's not the whole picture. So what else is there? Is it disability? This is Canadian data, again, from the Canadian Community Health Survey, and as we can see, dependence in basic activities of daily living like bathing and washing increases as you get older. Dependence in instrumental activities of daily living like cooking and looking after your pills and transportation also becomes more common with age. So maybe that's part of frailty, isn't it? But not all frail people are disabled. So disability is part of this definition, but not the whole thing. What about these things called geriatric syndromes? So that's what geriatricians do. They see people with geriatric syndromes. And there's a really nice study from the US that actually looked at geriatric syndromes and compared that to medical illnesses. And I like to show this because All of these geriatric conditions that really don't make the headlines are as common as those that do. Look at urinary incontinence. It is more common than heart disease in this sample, right? Falls is more common than psychiatric disorders in this sample. These things are huge. They're very, very common, and we never hear about them. And like multiple morbidities, like disabilities, they are more common with age. So people who are 85 and over have the most number of these geriatric syndromes. And interestingly enough, having geriatric syndromes is sometimes worse in terms of disability than having a stroke, for example. Again, this is the same data from this US study, that if you have 2 or more geriatric conditions, hearing impaired and, say, urinary incontinence, you are more likely to be disabled than if you had a stroke. So I think we're starting to get there. So multiple comorbidities, that's part of it. Disability, that's part of it. But these geriatric syndromes, these things like incontinence and hearing loss and visual impairment that we tend not to think about as being that important, they really are. So frailty might include multiple morbidities and these disabilities and these syndromes, but I don't think that's the whole thing. There's more to it than that. Look at the following data. Again, this is Ontario data from CIHI. These are costs of inpatient hospital services by primary diagnosis. So whatever the physician writes on your discharge summary as the main thing that brought you into hospital, that's the primary diagnosis. And as Frank said, look at the cost of a dementia-related hospitalization, $20,000. And obviously there's more cases of those as people get older. Heart failure, fractured femurs, which is basically because of falls, COPD. And I put those out there because the other things that we often hear about are important, but certainly not as important as those. If we look at RLIN in Waterloo, Wellington, we looked at acute length of stay and ALC length of stay days for the top conditions. It's the same ones. It's dementia, it's heart failure, it's fractures, and it's COPD. And in this case, the separation between those and the other diseases is quite striking in terms of number of cases and hospitalization days. And why are these important? Because they cluster together. And I think that's part of the dynamic component of frailty that we often have trouble explaining. And so if you look at all these 4 conditions, you've got dementia, emphysema, COPD, heart failure, and falls. How are they related? Patients with dementia are less likely to take their puffers properly and therefore more likely to end up in hospital with exacerbation of their emphysema. People with dementia don't take their heart failure pills. They don't recognize when they get sick. They get hospitalized more often. They get more disabled. They die more often. Dementia is a risk factor for falls. People with COPD are more likely to have cognitive impairment. People with heart failure are more likely to have cognitive impairment. 80% more likely, given it's for the same age. People who fall end up in hospital and get delirious, especially if they have cognitive impairment. So you're starting to see that these things interact with one another, and basically you end up with this cycle where patients deteriorate for multiple reasons. They get functional decline, they develop incontinence. People don't think about COPD patients, but they cough. And when they cough, they develop incontinence. Heart failure patients, we put them on diuretics. They go to the bathroom more often. They get incontinent. Mental health issues all come with these conditions. You're more likely to have depression and anxiety with these conditions. You're more likely to have multiple medications, therefore leading to drug errors and adverse events. And they are also more likely to have diabetes and hypertension and all sorts of conditions. Their caregivers get stressed, and these folks end up in hospital. And so all of these conditions don't just stand alone. They interact together, and they feed off of one another and make each other worse. And patients eventually end up in this cycle of ongoing decline. And really, in a sense, that's where frailty comes in. So the frail person has multiple illnesses, but has disabilities, has all these geriatric syndromes, and once this sets in, things start to feed upon each other, and you end up in this cycle of ongoing decline where you end up in hospital. So frailty is a very dynamic thing, and it doesn't take much to set it off. So if my father were to fall tomorrow and break his hip, knowing how he is, he's going to have a terrible, terrible time. And so the question is, can we do something about it? And yes, there is something we can do about it, and that's what the geriatricians do. We do comprehensive geriatric assessments. And it's a fairly lengthy process, but as you can see, for a frail person, you have to take the time to go through all of these things. You look at their mood, their health, their medications, their function, their resources, their supports, the caregiver. You also have to be able to understand the degree of frailty. Remember, you saw that frailty scale. You should be able, as a geriatrician, to sort of figure out where they lie here, because you're going to develop a plan of attack to address all of these deficits, but you're going to tailor that plan to their degree of frailty. So again, speaking about a frail person with severe dementia who had a heart attack, it might not make sense to put them on a cholesterol pill because they're too frail, and you're not going to get any benefits, and you might make them worse off. Or they might not be a candidate for cardiac surgery because they're too frail to sustain the complications of that. So that's what geriatricians do. They assess, they develop plans of management, but they're able to tailor these plans of management to the overall degree of frailty. And I wish that was a nutshell, but it's really complicated, and one of the challenges is to try to distill that and explain it to people in a simple way. So I hope this works. And we know that if we do this to the right person, they will do better. There is tons of evidence about geriatric assessment, improving prescribing, improving function, improving cognition, and more importantly, for the system's perspective, less nursing home placement, less hospitalization, lower mortality. So for the right frail person, having a specialist do this procedure called the geriatric assessment is a very useful thing. But we have a conundrum. In Canada, in the US, many places, there's not a lot of us. And I think the most recent data is from September from the Canadian Geriatrics Journal. They could never decide on a number, but either way, it's a low number. There's probably at most 240 geriatricians in Canada, and perhaps something like 320 functional specialists, which would include care of the elderly, family docs, or general internists who do geriatric medicine. And importantly, over a third are going to retire in the next 10 years. Just as the baby boom is starting to increase right now, the geriatricians are set to retire, and we're not recruiting the replacements. The need, perhaps double, no one's really sure, but certainly there's a shortage. And where do the geriatricians hang out? In Canada, mainly academic health sciences centers. Interestingly enough, I'm no longer in a traditional med school setting. We do have 5 geriatricians. We're actually very well resourced relative to others. We still need geriatricians, but most of the geriatricians are in the med schools. Others are in hospitals. And as you can see, some are in long-term care, but certainly in my LHIN, very few people go to nursing homes, and very few are in the community. So as a group, we generally cluster in hospitals and not necessarily in the community. What do? Most of us are doing inpatient work. We all have outpatient clinics, but a lot of us do consult services, GAUs, ACE units, hospital-based day hospitals, things like that. Is this where we ought to be? And again, that's one of the questions we have to ask ourselves. Is it good enough for us to be in the hospitals where often the patients we see have had a frailty-related event? Or should some of us be out there trying to prevent these events from happening in the first place? So when I came on Waterloo Wellington, I basically set out and did a lot of focus groups. Waterloo Wellington is relatively small compared to Champlain, but it's an interesting LHIN. It's got urban areas in the south, it's got Mennonites, it's got a lot of farm country, and it's a very interesting mixed kind of LHIN with lots of rural, lots of urban, non-teaching hospitals. And so I set about, and call it the world tour because I had no idea what else to call it, basically to go and do focus groups and figure out what the needs and challenges are for our region. what changes were needed to the healthcare system in Waterloo Wellington, and how we should set about trying to put everything together in a more integrated way. And the report's very long, so I'll just skip to very few short messages from this message. We did a lot of focus groups, 20. We interviewed 186 people. About 30 people were actually care providers or patients. And we did this the correct way. We had this analyzed properly using proper qualitative methods. And essentially, this is what we found I'm not going to give the whole report, but basically everyone agreed that primary care was great. I think 98% of seniors in Waterloo Wellington have a family doctor. This is fantastic. The family health teams were pointed out the community health centers as particularly good. Specialized geriatric services, great. Everyone loved it. Community support services were great. Everyone loved them. But they kept telling us, why don't you guys talk to each other? Why can't you work together? The way the system is set up, it reacts to crises and does nothing else preventative. It was very poorly integrated. I had patients who had mini-mental so often that even if they were moderately demented, they could still remember the mini-mental. And they passed it. That's how absurd it was getting. So the challenges identified, not only is the system very fragmented, but primary care capacity to manage frailty was cited as a major deficit. This notion of person-centered care. So you would go to a provider and they would say, we can offer you this. But the patient would say, but I need that. Sorry, this is what we do. You're out of luck. And there was no mechanism to say, well, if I can't do this, you should go there for that. Nothing like that is going on. And there was a strong message that they wanted the geriatricians helping out primary care in the community before the wheels fall off and you end up in hospital. That was quite clear. That was one of the strongest messages that we had. So one of the recommendations really was greater integration of specialty care with primary care in order to be more proactive about managing frailty. Again, a geriatrician can look at someone who is deemed requiring long-term care placement and reduce the need for nursing home. There's no question that this works. But the challenge is, can we get to them before people think they need long-term care? So, what about this idea of managing frailty? We manage diabetes using chronic care models. We manage heart failure using chronic care models. What about frailty? Can we manage frailty using the chronic care model? So you might ask, what's the chronic care model? Chronic care model has multiple elements to it, and there's a lot of jargon associated with that, so I've tried to distill it in a way that makes sense. But one of them is focusing on self-care skills. Instead of doing things for people, we try to get them to learn how to help themselves. And believe it or not, that works. That works in heart failure, in diabetes, and it may even work in dementia care. If you give people the tools to know what to do and how to play the system, they actually do better. Care integration and coordination. So one of the examples is in Waterloo Wellington, depending on where you were, you had a different CCAC case manager. Why not the same one? Why not keep the same person throughout the system? Different areas use different tools to assess patients. Why not use the same tools? Because people get reassessed all the time, and you spend so much time assessing, you do nothing about managing. Access to multidisciplinary resources. Geriatric services are often, not always, richly supplied with allied health. And that's one of the nice things about being a geriatrician. I get to work with allied health. But most community providers do not have that access. Why not? And obviously clinical information systems, and that'll be your forte in the future. But eventually, you need to have good electronic records, because that is what drives reassessment. I don't know what you had done over there, so I'm going to do it again, even though you had it done 2 weeks ago. But more specifically, what chronic care management requires is you need to risk stratify. Okay? You can't give every single senior the $1 million treatment. They'll do well, guaranteed, if they get the $1 million treatment. They may not need it, though. And so there is a need to target patients. You need to target the more intensive interventions to the more high-risk patients, and you need to give the lower-risk folks the right intervention. So when you talk about that, basically some seniors are fairly low risk. They're going to do well, they have chronic illnesses, and usually do well in the usual primary care approach. Mid-risk patients, perhaps not like my dad, I think he's higher risk despite what the assessors say, but lower risk patients who are slowing down might ideally be looked after in a primary care system with access to allied health, ideally co-located, perhaps with occasional input from the specialist. In that way, you reserve the specialist and the intensive, expensive care for those who are really, really high risk. So these resources should be directed at the really high risk patients. In primary care, there's a lot of chronic disease management going on, and the interesting thing is that very little of it has anything to do with seniors, unfortunately. So this, Coleman published a systematic review of 56 primary care, chronic care model randomized controlled trials, and most of them looked at single diseases, and most of it was diabetes, depression, asthma, and cardiac risk factors. And as you saw from the data earlier, that's not what's causing problems in hospitals. It's not COPD or heart failure or dementia or fractured hips. We're not actually doing the right, we're not focusing on these diseases at this point in primary care. But they did identify the key factors for successful primary care. And that's, again, getting back to this topic of where do specialists fit in primary care. So keys for success in primary care is you have to redesign the way that care is delivered. 5-minute appointments do not work for chronic diseases. And those programs that are able to redesign care programs so that the family doctor has more time to spend with the person, that allied health has more time to spend with the person, tend to be more successful. And you really have to engage your allied health based on their skills. I remember hearing about one family health team in Arlin who got a nurse practitioner, and they had no idea what to do with her. So they got her to do pap smears. That's not going to work. You know, these people are specially trained and they're highly trained, and you have to capitalize on their training. This includes integrating specialists into these primary care programs. When specialists are integrated within these primary care programs, outcomes are generally more positive. So having the specialists even co-located with these clinics is an indicator of success. And obviously electronic records is important, but care process redesign, basically changing the way the care is structured, is key. Using interprofessional resources, and that means having the specialist available at the primary care level. And the RGP here did publish something fairly recent on barriers specifically related to dementia in primary care. And some of the problems in primary care that prevent dementia management include unfamiliarity with the condition, delays in diagnosis, not knowing to take complaints of memory seriously, not knowing what the appropriate workup is. Caregivers sometimes also dismiss memory complaints as not important. And so at the primary care level, there's a lot of barriers here. Lack of training and awareness. I mean, you can get by in Canada with about 40 to 60 hours of geriatric training before you become a doctor. 60 hours compared to 300 or more for pediatrics. That's a problem. Family doctors are often not aware of support services and how to access them. And again, most primary care is delivered in a very brief, episodic manner. And family doctors who want to spend more time aren't paid to do it by OHIP. So those are important barriers. So I'll talk about a model in Waterloo, Wellington that might be closing in on this chronic care model. And a lot of these slides were given to me by Dr. Linda Lee, and she's a family doctor in Kitchener who developed this primary care model. Basically because at the time, the wait lists for a geriatric consult were about 6 to 8 months. And she had a particular interest in dementia, and she decided, after her family health team had been created and they had all these allied health professionals, to see how they could design their care processes in a way that could allow them to handle dementia. And so they did a lot of basic focus group work, which involved a lot of education of the allied health about dementia, and figuring out what jobs could be parceled out to allied health and what jobs could be then done by the family doctor in a more time-efficient way. And they developed this primary care memory clinic, and I'll show you some of the things, some of the processes, how they do it. At this point, there are now 30 memory clinics trained across Ontario using a College of Family Physician accredited 5-day training program. So this program has actually gotten quite large. It has regular annual CME days and ongoing web-based webinars for ongoing education related to dementia. But it's gotten very big very quickly. And this is what a clinic looks like. So essentially, within a family health team, which may include a number of family doctors, 1 to 3 family docs will say, you know what, I'm interested in this, and I will take on dementia for you for the rest of my clinic. The rest of the team members include the nurses and the NPs, a social worker, pharmacist, very often Alzheimer's Society members, and most of these clinics have a specialist affiliated with them who will either see patients or be accessible by email or telephone for feedback and consultation. And the goal here is to help the family doctors in the family health team who have patients with memory issues to have the patient assessed within primary care, have a plan of management developed, and then have guidance on how to help manage this patient. The goal is not necessarily to take over care, but to do the assessment and help the family doctor along and learn how to do this him or herself. And the reason is, again, this came out of a need because in Kitchener and Waterloo in 2005, the wait list was 8 months and people were waiting and getting sicker. So how it works is a family doctor in the family health team has a patient who's got a memory concern, and now they're doing a lot more case finding. They're aware about dementia, and that was one of the benefits in that family health team. People think about it, so they ask. The referral is made, and the team essentially takes 2 or 3 hours to assess the patient. They'll do a medical and social history, there'll be cognitive testing done by a nurse, and the pharmacist will do a med review, the social worker will speak to the caregiver, and then they have a team conference, and they will review everything, and the physician will see the patient, do some additional history and physical examination, and then they will develop a plan of management, and that may include referral to a specialist. The report is sent off to the family physician immediately because it's done in the same family health team using shared electronic records. So a note is put into the chart and the email is sent right away to the family doctor that I've seen your patient and here are the recommendations. So the feedback is immediate. And then follow-up is usually by the family physician. If problems arise, they can go right back to the clinic and ask for advice. So a paper was published in JAGS in 2010, and the most recent paper is being finalized. So Dr. Lee did get a CIHR knowledge transfer grant to evaluate the second set of training. So she evaluated 5 family health teams that were part of the second tier of training for the memory clinics. And essentially we're talking about family physicians and allied health from multiple memory clinics, in fact 21 family health teams and 1 community health center in Ontario. Large variation in the size of these family health teams, up to 118,000 patients in one of them. Most clinics had at least a physician and a nurse. And all of these teams were trained in that 5-day interprofessional workshop. So basically the training is 2 days of case-based dementia learning and workshops, 1 day when the new team goes to the primary team in Kitchener and observes a memory clinic functioning, and then the team being trained has its first 2 days of memory clinics with the chaperoning team observing them and helping them along. So that's the 5-day training program. Basically, these clinics saw about 582 patients over a year. About 30% of them have at least 1 follow-up visit. The wait list, about 1.4 months, which is still shorter than wait lists for geriatric consults in Arlene. 35% are seen within a month, and about 9% are referred to specialists for frontal lobe dementias. There are very specific referral criteria, so any gait problems, any evidence of behavioral issues that are severe, frontal lobe dementias, Lewy bodies, unusual dementias get referred to the specialist. And so the referral rates are about 8 to 9%. There's an interesting variation, though, from 2 to 23%, and I'll talk a little bit more about that. 40 chart audits were done for these memory clinics by 2 geriatricians independently. So the question is this good work? It's always a question about this. And so the College of Family Physicians has a template for chart audits, and 40 charts were pulled from 5 of the memory clinics, and they were independently reviewed by geriatricians using this template. If there was disagreement, the geriatricians got together and came to some sort of consensus about the quality of the work done. And by and large, there was very good agreement on the diagnosis, the investigations, the lab tests, the treatment plans, and the use of medications. So this seems to work fairly well. It's not perfect, though. I mean, you'd like to see a bit higher than 90%. Maybe I'm a perfectionist, but from the interviews that were done with family members, they liked that they got seen quickly. They liked that they got diagnosed quickly and interventions were begun fairly quickly. In some of the more mature teams, there was fairly efficient management of crisis situations. They like being looked after in their family doctor's office. That's something that we don't think about often when we send patients to clinics elsewhere. There's a comfort level that they have but being seen in their usual family doctor's office. There was increasing access to community supports, and the caregivers felt relieved of the stress, and generally they were quite satisfied with the care. So where do specialists fit in? I want to get back to this. So as you heard from Frank and many others, there's growing recognition that dementia is a huge, huge problem. And it's a huge problem not in and of itself, but as you saw with my other slides, it's an underlying problem in the management of all these other conditions, of heart disease, of diabetes, of COPD, of falls. It's kind of like a linchpin condition. And if you don't deal with it, not just by itself, but as a factor for hospitalizations for other things, you're not going to solve this problem of all these ALC patients ending up in a hospital. The issue is, though, there's not enough specialists, and we need to involve primary care in a constructive and useful manner. It's important to remember that specialists are not family doctors. And I work in 2 family health teams, and it's quite clear to me that family doctors are true specialists in providing ongoing care. We're not. We're consultants. We'll see some follow-ups on a regular basis for a while, but that's not our job. We're there to consult. So the true specialist of ongoing supportive care is the family doctor. The trouble is there's so little evidence out there on how to get the 2 to work together. Potential roles of the specialist. Obviously, we see patients, and I see patients for some of these family health teams, and I find it extremely efficient, because I see very complicated patients, but they're so well worked up that I don't have to spend excessive amounts of time sorting things out. The questions I get about the patients are very focused, and it's easier for me to see a patient and discharge them back to the family doctor because I know that they can handle it. So that's a very efficient thing from my point of view as a specialist. In direct services, I do a lot of reviews with the teams and lots of phone and email support. So that's a direct and indirect clinical role of the specialist. Another role is this idea of capacity building and knowledge transfer. Often as specialists, we're targeted by the companies about the new therapies. We're the first to hear about these things. And ultimately, the therapies get disseminated to primary care. Sometimes not that well. Some drugs are overused, some drugs are underused. Here's a role for specialists who will understand how to use new therapies, and there's a way of disseminating that knowledge in a very efficient and correct way to primary care. And again, this memory clinic program is interesting because they have annual CME events where this could happen. They have ongoing web-based seminars when this could happen. Quality assurance, there's another role for specialists. And the first paper that came out, agreement of the specialists with respect to the quality of care was very high, 97%. And as you've seen in the second round, it was 90%, still pretty good. But there's an important issue here. These are family doctors who are really interested in learning about this, and they do have an interesting approach with the 5-day workshop, but there needs to be a mechanism to ensure that the quality of the care is maintained and continued. And I think there's an important role for specialists here to improve the quality of the quality assurance. Perhaps even more formal mechanisms through the College of Physicians. Another role is, and it's been a role that I've taken on in the LHIN, is advocacy and education. When I first started working at the LHIN, there was little understanding of what frailty was. About 2 years doing talks on frailty and trying to figure out a way to push the right buttons, and it's finally happening. Frailty is not that simple a concept to explain, but certainly it's something that we need to do a better job of explaining, because the problem with the hospitals being clogged is it's because they're full of frail people. The other message that's really important, and it's not getting through yet very well, is that frailty can be managed. We can help these patients and make them better. A lot of the time it's, guess what? You're just getting old. We can't fix you. That's wrong. It's an attitude that's got to be changed. So the final challenge I have for geriatricians is I don't think we do a good job of selling our skills or branding ourselves. And despite the fact that we're a real specialty, despite that there's a very large base of evidence in geriatric medicine, despite the fact that 1/3 of the articles published in the scientific literature on geriatrics come from Canada, there remains this perception among people out there that this is not, we don't have an expertise that's usable, that's useful, or they don't seem to be aware of that. And I think we've done a poor job of selling ourselves as really, I think, the most useful specialty in helping primary care deal with these complex, frail patients with all of these multiple comorbidities and disabilities and geriatric syndromes. And I think we do have a significant role as a specialty in terms of working more closely with primary care to solve this issue. So I think we're running out of time, but as Frank said, I think dementia is one of those key things. And you have to consider it as a keystone disorder. And the challenge, though, will be to do dementia right. But once we do dementia right, then we need to start looking at that demented patient who's falling, who's got heart failure, who can't breathe, and start branching out from that point of view. And essentially, this is an area, and I'm appealing to all the researchers here, that there's very, very, very little literature on how to do this right at this point. So I think the understanding frailty, understanding its complexity, understanding that it's a dynamic process, and understanding that this is what drives morbidity and health service utilization in an aging society is an important message that's got to get out there. Even more importantly, we need to get people to understand that we can do something about it, and fostering closer collaboration between primary care and geriatric medicine is imperative, especially if you want to start getting frailty earlier, before they end up in hospital, before they end up in nursing homes. So again, is a challenging thought, is it time for geriatricians to start getting out into the community to a greater extent than we already are? So I will stop here because I'm losing my voice. Thank you.